Hello, everyone. Good morning, and welcome back for day 2. We have some incredible things in store for you today, but before we get started, I wanted to take a minute to share some insights on the 2024 Family Gathering theme, Transformation, the Power of Change. This simple aspect of the event brings me so much joy. As I see it, the theme is one more opportunity for us to celebrate our strengths, a chance for us to dive deeper into what it is that makes our community unique and something we can all rally around. It's no secret that for each individual and their family here, their journey's been altered by that one thing that brings us all together, an FOP diagnosis. The obstacles this condition creates in our path can be challenging and test our community in many ways, but will also present opportunities for us to evolve as leaders, sharers, and givers to one another. Transformation, the Power of Change, is an invitation to see each trial as an opportunity for growth and good, along with the bad. So I ask you to consider throughout our next 2 days together, what does transformation mean to you? For my friend Elena, the only known person in Romania with FOP, it meant taking the moments in life when she was impacted by her FOP progression as an opening to pause, find herself, and grow. She shared this slide during a session she hosted as a part of our Resilient Living program earlier this year. During that time, she used her expertise as a certified life coach to guide participants through activities that they could incorporate into their daily lives to channel their perspective as a tool. To my friend Jack, who I met at the 2019 Family Gathering, just 31 years after he had met Jeannie and the 9 other founding members of the IFOPA, the idea of transformation was the detailed work of a butterfly in watercolor. To him, his art showed that what can be done after adapting to FOP. Jack was a right-handed painter until his right elbow locked, forcing him to do most of his painting with his left hand. The painting you see on the screen was the first time he had painted an open-winged monarch butterfly using his left hand. He considers this to be one of the more difficult butterflies to paint. Through his work, he wanted to show that people with FOP can have productive lives. Jack sold his art at exhibits and craft fairs around the state of Minnesota until he passed away last year. I'm standing up here sharing these 2 examples of transformation from friends that couldn't be here with us today. My hope is that all of you will find your own stories of growth and beauty in conversations with one another and in your own story down the road. With that, I'm grateful to be able to introduce you to Susan Rhee, Senior Medical Director at Regeneron, who will be joining me and welcoming you back before we start our first session.
Morning, everyone. Hello. Hi. My name is Susan Rhee. As Hope said, I'm a Senior Medical Director at Regeneron. I'm here to give a welcome message to you, actually on behalf of my colleague, Amanda Sivcharny, our Executive Director of Patient Advocacy, who was supposed to give this, but unfortunately, due to a family emergency, could not attend this meeting. So she's actually pretty sad she's not here. But multiple of my colleagues have joined me in attending this meeting, and many of them have worked in rare diseases for years. I wanted to thank the IFOPA for the opportunity to welcome you all to the 9th Family Gathering. We are delighted to be here. We are proud to support this meeting and strongly believe in attending to learn about the important work of the IFOPA. The team at Regeneron is also here to learn with and from all of you to continue to grow our understanding of FOP. At Regeneron, our mission is to use the power of science to bring new medicines to address unmet needs. We let the science lead by developing therapies in-house, and the company is often recognized for its innovation, long-term vision, and social responsibility. Working in the field of rare disease is in the company's DNA. Our first FDA-approved product was for a rare disease. At Regeneron, we pursue foundational science that can impact diseases with both large and small groups of patients, and to do so, we leverage cutting-edge research tools and unique resources such as our Regeneron Genetics Center to further understand the genetic variations that might protect someone from a disease or make them more susceptible. We then use novel technologies pioneered by Regeneron to further understand the root causes of disease and identify potential new therapies. Through this approach, we've created numerous approved and investigational medicines for people with rare and ultra-rare conditions. Scientists in our skeletal diseases therapeutic area have been focused on understanding and developing potential therapies for multiple conditions, including FOP, for more than 20 years. Over the past 6 years, Regeneron has been present at both family gatherings and drug discovery forums inside and outside of the US, and today we reaffirm our commitment to the FOP community. So again, thank you to the IFOPA, Hope, Michelle, and the team for putting together a fantastic agenda and creating a great meeting for the community. Thank you.
Thank you, Susan, and we are grateful to Regeneron, our visionary partner, for making this year's family gathering possible. We'd like to take a moment to share our appreciation for all of our family gathering sponsors: Regeneron, Ipsen, Insight, and Ashibio. Now, what you've all been waiting for. Our first session is being presented by an incredible group of FOP medical experts. We'll hear from Dr. Robert Pignolo, Dr. Ellen Elias, Dr. Mona Almukanam, and Dr. Ed Schau, who will then be joined on stage by Dr. Fred Kaplan for a special Q&A. We will hold all questions and answers until the end. Once Dr. Schau has finished his presentation, please feel free to raise your hand or use one of the question sticks on the table. There is also a mic on the left side of the room if you'd like to get up and ask your question there. So with that, I will hand it over to Dr. Pignolo.
Good morning, everyone. It's great to be here. So this morning I'm going to give a presentation about what the future of treatment in FOP might look like. So the title of my talk is Therapeutic Horizons for FOP. And these are my acknowledgments. But the outline of my talk is going to be perhaps a little bit different than you're used to hearing. I'm going to start with targets. So targets are important because we need to appreciate why we have certain treatments. And so I'll spend a little bit of time talking about the major targets for current and future treatments. And of course, I'll spend time talking about what those treatments might be. And finally, of course, we need to appreciate what the challenges might be to realizing what those, ultimately what those treatments for FOP might look like in 5 or 10 years. So let's start with targets. So prevention has been and always will be one of the major targets in the management of FOP. This table lists some of the things that we need to consider when we talk about prevention, those things that are safe or encouraged, and those things that are unsafe or discouraged. So I'll give you some examples. So the active movement of joints is encouraged, passive movements of joints is not. Subcutaneous injections are safe, but intramuscular injections are not. Routine measles, mumps, rubella immunization administered subcutaneously are safe, but routine diphtheria, tetanus, and pertussis immunization administered by an intramuscular route is not safe. Routine venipuncture is safe, arterial punctures are not. Precautiously administered dental care, safe. Overstretching of the jaw and intramuscular injections of local anesthetics are not. We encourage activities to improve respiratory function. We encourage that expert guidance is sought for procedures that involve general anesthesia. We discourage activities with high risk for falls and injuries. We encourage staying well hydrated, especially to avoid kidney stones. We encourage the practice of preventative dental care, and we encourage early screening for hearing loss. Perhaps the most important target for future FOP treatment is the causative ACVR1 mutation and the ligands that bind to this receptor. And I think we mentioned last night that the gene discovery was made in 2006. And on the left side of the screen, you can see a schematic of the gene. The R206H mutation is written in green, and that accounts for about 96 or 97% of all FOP mutations. And then there are several variants that either confer lesser or more severe phenotype. And on the right is a cartoon of the ACVR1 receptor. And I think in terms of our talk about targets, the important things to know are, one, that normally when activin A, which is the ligand for ACVR1, is bound to the receptor, that signaling is in fact inhibited. But that in FOP, binding of activin A to the receptor makes the signaling pathway active. So both the ligand and the receptor are targets for future treatment. And then in the bottom right, you see another cartoon of an area of the receptor called the kinase domain, and more about how we have used these targets to generate potential therapies. Another target is the lesion formation in FOP. So when we see clinically a lump or a bump at the cellular level, at the level of the tissue, lots of things are happening. And so initially there is a dramatic infiltration of immune cells, and they sort of invade the muscle tissue. And then there's a sort of fibrosis, that is, there's a scar, almost like a scar formation process going on. And then after that, there's a process that we call endochondral ossification, which basically means that in order to form extra bone in FOP, you first need a cartilage template. And then I'll give you an example a little bit later of how some of these targets are being translated into potentially meaningful therapeutics based on what's happening at each stage. And one other major target that we recently described, and Fred Kaplan will go into great detail about this tomorrow, is the genetic basis for resilience. So that is a new and unexpected target in a resilient patient. And in this case, the target is a protein called matrix metalloproteinase 9. And I'll just plant the seed today, because tomorrow you're going to hear a lot about this, and I don't want to steal any thunder, but just to make you realize that this is another target that we look forward to seeing if it can be translated therapeutically into a meaningful treatment. Okay, what are our treatments that we can anticipate over the next 5 to 10 years? Well, I think we're still going to use corticosteroids the way we do now. Currently, we give a brief 4-day course of high-dose steroids, and we try to start that as early as possible after we realize that a flare-up is occurring. We usually restrict the use of high-dose steroids to major joints, the jaw, the submandibular area, to prevent flare-ups following a major injury or trauma, and then to prevent flare-ups in emergent, elective, or minor surgeries. However, the problem with using steroids is that only about 12 to 20% of flare-ups completely resolve without loss of function. And so although steroids improve flare-up symptoms, and that would be the major reason to continue to use them even in the setting of new medications, steroids uncommonly result in complete resolution and also uncommonly prevents the formation of heterotopic bone. And so currently, this is the problem. This graph shows that the rate of progression based on the change in a score of mobility over the change in age as a function of age. And what's important to realize here is that by the mid-20s, this curve is plateauing, and that means that most of the joints are already locked. And so this is the reason why we always say the battle in FOP is won or lost in childhood. So we want to make sure that the window of opportunity is taken with these new treatments. And we also want to be able to identify drugs that are so good that in older patients who have reached this plateau, there's the possibility of surgically releasing a joint that was otherwise locked. So this slide is a little bit busy, but I think it's important to look at and appreciate that for such an ultra-rare disease, we've already identified so many targets, so many places where a potential treatment is possible. I've already mentioned some of these. So the intense early inflammatory response, MMP9, the causative mutation, that is the ACVR1 receptor, the ligand that binds to the ACVR1 receptor, the endochondral process that requires a cartilage template before bone can form. So we've identified so many targets. And on the left side of the screen, you can see what those potential treatments might be to focus in on those targets. And probably most importantly, you can see on the right all the clinical trials that are either ongoing or have been completed. And you can see that there are currently 3 clinical trials that are targeting the kinase domain of the ACVR1 receptor. There's the Lumina Optima trials that focus on the ligand, activin A. There are anticipated trials as well, and there is the MOVE P1 study that have essentially served as the basis for regulatory approval in some countries. So what I'd like to do next is focus on 2 of these treatments that have progressed the furthest. So this data is from the MOVE trial of palovarotene. I've reproduced the histology of the FOP lesion there on the left to show you where in lesion formation that palovarotene is most likely to act. And then I've shown you in the middle of the slide two graphs which show a reduction in heterotopic ossification. 2 things you should be aware of. One is that these are post hoc studies, and meaning that these were not the original analyses that were described in the protocol for the clinical trial, but these were analyses that were done after the fact. However, multiple post hoc studies have been done, and they all show that between 50 and 60% of heterotopic ossification is reduced in comparison not to a placebo group, but to a group of patients that participated in a 3-year natural history study. So palovarotene is the first medication approved for FOP. It's approved in the US and Canada and Australia, but not in the European Union. The brand name is called Sohonos, and that's available for purchase with prescription by a physician in a country where it's approved. But assuming that one does not have insurance, they would need to have the financial means to purchase the product. And the table just shows the various doses that are available, and those of you who are familiar with palovarotene and did perhaps participate in the MOVE trial know that there's a chronic maintenance dose, and then there are flare-up doses. And so far, there are about 35 people around the world on palovarotene. So this is some data from the Lumina-1 trial on garetosmab, and garetosmab is a monoclonal antibody which targets the ligand to ACVR1, which is activin A. And so I've reproduced the cartoon there on the left and showing that these monoclonal antibodies prevent the binding of the ligand to the receptor. And importantly, the data that I'm showing here is that garetosmab reduces new lesions, either looking via a whole body CT or PET CT. And the ongoing Optima-1 or Optima trial is, we look forward to those results to see if these results can be repeated. So this is sort of a little bit of a summary slide. And again, it's here to illustrate the tremendous progress that we've made in such an ultra-rare disease. Most of the current clinical trials involve the targeting of the kinase domain of the ACVR1 receptor, but there are lots of other targets, and each of those potential drugs for those targets are in various stages of development. And these trials are being conducted all around the world, both to assure that we can meet the study recruitment goals, but also to assure that if a drug is approved, that patients all around the world can have access to them. Okay, what about challenges? Well, all of the trials that I've mentioned so far deal with heterotopic ossification, but that's not the only thing that the receptor confers. So this first challenge that I've listed is there are complications not due to the burden of heterotopic bone formation. And I've listed some of these things here. Patients with FOP have a 3-fold increase in the likelihood of kidney stones, alopecia or hair loss, subcutaneous lipodystrophy, which means that the subcutaneous fat under the skin is lessened prematurely. There are myelination defects, which give some patients an MS-like syndrome. There's accelerated arthritis. There's other types of inflammation, and in women, menstrual abnormalities. So these are probably not due to heterotopic ossification, but other effects of the mutated receptor. We don't know how or if any of the drugs we're currently testing will address any of these other complications. So another challenge is that there are special considerations for clinical trials that involve FOP. Last night, I think you heard a little bit about the International Clinical Council on FOP, or the ICC, We're a global body of experts that really try to advocate for safe and efficacious clinical trial design and other aspects of management of FOP. In terms of clinical trials, we'd like to see that there's relevant preclinical data to move an intervention forward. We hope that innovative clinical trial design will continue to support the recruitment of fewer patients while still giving us important information. We advocate for common endpoints so we can compare the results among different trials. Of course, there are FOP-specific medical factors that we also have to take into consideration. We realize that we want to have a treatment not just for younger adults, but for children as well. So we need to consider things that would allow younger patients to participate in these trials. And we do all of this for the major reason to assure the safety of individuals with FOP. And we also advocate for cooperation with the pharmaceutical companies that run these trials in terms of data sharing and especially medication access. So lots of special considerations that are sort of balls in the air, if you will, and a little bit of a juggling act, but we're very keen on making sure that all of these things happen. Another special consideration for clinical trials is really the paucity of known patients. So there's about 7.6 billion people in the world. FOP affects about 1 in a million. That means there's about 7,600 individuals with FOP worldwide, and we know of about 834. The current major clinical trials have recruited about 244 individuals, or will recruit that many, perhaps a little bit more, and that represents almost a third of the known patients. And so, as you can imagine, if we want to study other drugs, other interventions, we need to discover more people who are currently undiagnosed. We also have to be thinking about innovative ways to test new drugs. And this is not specific for FOP, but this is one paradigm that was described for rare diseases where one could screen multiple drugs at the same time. So in this example, there are 3 drugs, drug A, B, and C, and patients would be randomized to one of those 3 drugs. The idea would be to monitor for an early response to one drug, and then if that was not seen, the non-responders would be randomized to the other 2. But if there were a response to the first drug, then those subjects would continue to be on that drug. Another challenge, repurposing of drugs for FOP. What do I mean by that? So what I'm showing here are drugs or nutraceuticals that have been reported to reduce HO in either animal models or in case reports. And in the case reports, it's not so much a reduction in HO, but really a clinical response to those drugs. And so you can see how long the list is. So the list on the left are those drugs that are currently available by prescription, and the 2 on the right are those that are currently available if you walked into your local health food store. How do we know to recommend any of these? Well, we don't and we can't, at least without some guidance. And the ICC recently put out a statement on the efficacy and safety of repurposed drugs. And the take-home here is really that we have limited data. We don't know if the potential benefit of any of these drugs is reducing flare-ups, which is what's usually reported in case series or case reports, whether there's any benefit for function or reducing heterotopic bone. We don't know about the long-term safety in patients with FOP. We may know about the long-term safety in other indications. And then what happens if a patient stops the medication? Will there be a tremendous rebound effect and then a period of time when FOP is just goes on a rampage? So how should we approach this in the absence of any organized effort to pilot these drugs in first-in-human studies in FOP? These are some of the suggestions that we put out in our statement. So if perhaps one should consider these medications if flare-ups are considered severe and intractable, or where there's an unusually severe or rapid progression of the disease. Once standard of care therapies have been exhausted, and if the clinical team feels that the medication could be used safely and according to the age at which the drugs have been already approved. Another challenge is the surgical release of locked joints. And as you can see, this is a big risk-benefit decision, and it involves the consideration for many, many variables: which drugs should be moved forward, how do you select a surgical candidate, which ankylosing joints should be intervened upon, how do you optimize the anesthesia, what does the perioperative management look like, what kind of physical and occupational therapy is done afterward, what are the appropriate outcome measures, what's the sample size, how long do you follow up, what does the design look like, how do you assess safety? So this is not a small endeavor, so the challenge here is how do you move forward in older individuals when we think we have a good drug that could be used in the setting of releasing a locked joint. And finally, how do we use combinations of drugs to treat FOP once we have several drugs approved? This is equally a challenge, but also an opportunity. And so one scenario might be that someone is on maintenance therapy, perhaps with a small molecule kinase inhibitor, and then if there's a breakthrough, a breakthrough flare-up, we might give a short course of steroids. Maybe we would treat episodically with something like palovarotene. Maybe we would add something else as a complementary agent. So I just want to conclude by saying that I think there's enough room for hope and optimism, but there's also a lot of challenges ahead. But I think the future is overall very bright. And again, for such an ultra rare disease, I think we're doing tremendous things, and I think we can look forward in the next 5 to 10 years to having multiple treatments, and we have to figure out how to use them safely and effectively. Thank you.
We had hoped to have our next speaker with us here in person, but it appears Mother Nature had different plans. So Dr. Ellen Elias is going to be joining us virtually. Can you hear me, Dr. Elias?
Yes, I can.
Very good. I'll hand it over to you.
Thank you so much. So I'm so sorry I could not be here in person today. The snow precluded my getting up there from where I live. But I'm so delighted to participate in this conference, and thank you to the organizers for inviting me. I actually live and practice here in Colorado. I am at Children's Hospital Colorado, which is the only academic based children's hospital for 500 miles in all directions. And I am the medical director of a clinic called the Special Care Clinic, which is a clinic where we care for children who have medical complexity. Next slide, please. So, what does it mean to be a child with medical complexity? Well, there's actually a formal definition of that, and it includes four different main cardinal domains. So, one of them is to have a chronic health condition, which may be severe, to require substantial health service needs, to have some functional limitations and things that a person can do, and to require high health resource utilization. Next slide. So, not all patients, particularly very little young patients, meet the definition of medical complexity when they're small. But because patients with FOP tend to have issues with which can progress over time, by the time they're mid to late teens, many of my patients have met the criteria for having medical complexity. And what's always important to know is that every patient is a unique individual, and it's very, very important to address the specific issues as they arise. Next slide, please. So as I was thinking of what to talk about for this talk today, I decided to focus on four main issues. One involves nutritional and feeding problems. The second is respiratory issues. The third, I'm not going to focus on specifically, but mention a little bit, which is the treatment of chronic pain. And then I want to spend some time focusing on how to help things go better at school. Next slide, please. So let's start with feeding problems. These can be very unique sometimes, depending on whether a patient has a jaw that is locked, whether they've developed contractures of their upper extremities, so that it's really hard for people to independently feed themselves. And this can lead to an inadequate nutritional state. Patients can sometimes have trouble getting in adequate fluids and adequate calories. Sometimes they have respiratory problems that have progressed so that they're aspirating and some of the food is not going into the GI tract, but into the lungs. And the consequences of this can include weight loss, malnutrition, various supplement and vitamin deficiencies, and often constipation if fluid intake is inadequate. Next slide, please. So how do we follow that? How do we assess for having nutritional issues and concerns? So it's really, really important for the patient's primary care provider, as well as whichever specialists are taking care of the patient, to follow growth parameters over time. Because you want to know, is a patient's weight falling off, and is their weight for height or their body mass index falling off? And is it necessary to give extra calories over a regular diet that a patient might not be able to take in as well over time? So some of my patients call me Dr. Dracula because I like to get blood. And as Dr. Pignolo described earlier, it's very safe to do lab work in patients with FOP. That kind of needle stick is fine. And so I follow some very clear nutritional lab work in my patients when I see them, especially if I'm watching the weight and seeing that that is starting to fall off. So I look at your blood count, that's your CBC. The CMP is looking at your kidney and your liver function, and there are a number of tests on that panel that tell me about nutritional function. I look at ferritin, which is a measure of iron stores, and the perfect level for that is about 50. Iron supplementation can be really difficult to do sometimes because it can cause tummy aches and constipation, so you have to do that carefully. But there are ways to do it in my patients with FOP. I follow 25 hydroxy vitamin D, which is the vitamin D form that you can measure easily on a lab test, and the normal is between about 30 in the mid 90s, and it's very, very easy, relatively easy to find vitamin D supplements one can find. One nutritional kind of an elemental metal is called zinc. And you get zinc in the same foods that you get iron from. So red meat is the best. Things like beans and spinach and kale. Some of those foods, especially the red meat, are harder for some patients who have jaw issues to take or for really younger patients to take. So both zinc and iron can drop and can easily be supplemented. I am very fortunate in my hospital. I have 5 dietitians who work in my clinic that help me assess these patients. And we can also do special studies if we need to, if we're worried a child has had recurrent pneumonias and is aspirating food into their lungs, we can determine if that is happening. And then vomiting can be an issue for some of my patients, that they're not able to keep down what they are able to get in. And so there are good medicines for GERD, which is gastroesophageal reflux disease, where the food comes back up from your stomach. And then there's also a relatively common condition in pediatrics called eosinophilic esophagitis, or EOE for short. And that's when you're having an inflammatory response inside in your gut that gives you abdominal pain and vomiting when you eat. And there are special medicines that help kids feel way better, and a good group of specialists who can help figure out if that's what's going on. Next slide, please. So it's often helpful to do a formal nutritional assessment. There are many, many different high-calorie formulas which are now available. Regular milk, whole milk, is 20 calories per ounce, but there are lots of special formulas. You probably heard of many of them. Pediasure is a common one, where they're 30 calorie per ounce, and there are even higher cal formulas, things like Pediasure 1.5 or Boost 1.5, where you can make sure that kids are getting in appropriate fluids and high calories. It's very important to treat those nutritional deficiencies I was just mentioning in the previous slide, and to not let the patient get really constipated, because if you're really backed up, then your appetite is terrible, and you can improve your appetite by keeping a good hand on the constipation. Next slide, please. So I'm going to move to respiratory problems in children who have medical complexity related to their FOP. Well, asthma is a common medical problem in pediatrics, and you can have any kind of common medical problem if you have FOP too. So depending on where a patient lives and the geography of that, respiratory disease can be much worse. So Denver is called the Mile High City because we're 5,280 feet above sea level. And so people who live up in the mountains or at higher altitudes tend to get into more trouble from a respiratory standpoint. I've been here now 24 years. I was in Boston for 17 before that. And my patients who live here at altitude get into trouble even with just regular colds. And then when you add onto that the constriction of the chest that may be related to heterotopic ossification in the thorax, and other issues related to chronic aspiration or asthma, you can get into more trouble from a respiratory standpoint. So some of my patients also see a pulmonary specialist. That can be really helpful to figure out what kinds of medications can help the child breathe more easily and then feel more comfortable, be able to eat better. Next slide, please. So, symptoms that you might see in a patient who's having these kinds of respiratory issues, they can have a chronic cough, their oxygen level might be low, that's hypoxia. There might be noisy breathing associated with either eating or the patient's position, whether they're lying flat or sitting up. Sometimes there's difficulty handling secretions. Snoring can be common. Restless sleep is a common problem I see. And that is often related to a very low ferritin or iron level. Poor growth can be related to respiratory issues. And if your sleep is really bad at night, then behaviors can be more difficult during the day. Next slide, please. So how do we actually assess if there's a true respiratory problem happening? So we often just think about checking what the oxygen level is with the simple little device on your finger. We can do that overnight. And sometimes if a child is having problems, but it's hard to get them into an overnight sleep study in the hospital, we can do that at home very easily these days. If we're worried about swallowing problems, we can assess for that. There are good meds that can help with drooling problems. We don't often do Botox because that's a shot into the salivary glands, and we try to avoid shots. But it's one option if the problem is very, very severe. Ear, nose, and throat specialists can really help assess to see if the tonsils and the adenoids have gotten enlarged and are partly obstructing the airway. And I have had patients whose FOP has not been diagnosed until they're much older, who have successfully undergone removal of tonsils and adenoids before their FOP was even known. Pulmonary consults and chest x-rays sometimes can help to see if there's chronic constipation, and the heart and the lungs work together. So if there's chronic obstruction for breathing, that can impact heart function. So we sometimes need to look at that. Next slide, please. So what can we do? We can give kids oxygen if they need it. We can use inhaled steroids like albuterol. There are many sleep medications in our armamentarium at this point that can be helpful. Melatonin is probably the most benign. And then there are some of my patients who can tolerate CPAP, which keeps the lungs, airways open, or BiPAP. Next slide, please. So one thing that's really, really, really important about respiratory problems is to do your very, very, very best to avoid them. So use your best judgment. If somebody wants to come visit, but they say, oh, I just have a little cold. Say, sorry, let's put this off and reschedule. Try to really avoid exposure to respiratory infections. The latest version of COVID, for example, is extremely contagious. And one person brings it home, and then within days, the whole rest of the family has it. So really do your best. So I'm a pediatrician, and so I have a kind of slightly different slant on immunizations, but you can safely, as Dr. Pignolo mentioned, give many of the common pediatric vaccines. Instead of giving them into the muscle, IM, you can give them under the skin, which is subcutaneous. So we have a protocol in my clinic, or for my 8 FOP patients, we can give them subcutaneous flu vaccines, and we have a special, protocol for that. Since COVID, there have been no trials proving safety of giving COVID vaccines sub-Q. So we're really not allowed to do that. Maybe someday there will be, but what the sort of recommendation is, if a patient has areas of heterotopic ossification, that you give the COVID vaccine there so that if a little bit more HO develops, it won't really severely further compromise a patient's status with heterotopic ossification. But COVID is a really, really bad player, especially the new version of it that's going around. And the new version of the COVID vaccine is designed to protect against that. So I really am strongly encouraging my patients to get flu and COVID vaccinated as we are now in the winter respiratory season. Next slide. So let's switch and chat about school. Having any kind of a chronic diagnosis, especially associated with flares that can recur, can clearly impact a child's ability to attend school in a consistent way and their performance. So per federal law, schools are required, it's the law, to accommodate the needs of children to allow the child to attend school in what's called the least restrictive environment. Next slide, please. So there's several ways to do that. There are medical plans that all children with FOP should have if they're having active plans, so that whatever activities are going on at school can be safe. This involves the school nurse helping to put this together, supervision on the playground, or in sports activities in gym, so that a child doesn't get injured that can lead to a flare, and having a more emergent plan in place should an injury inadvertently occur in school. Next slide. There's a special plan called a 504 plan, which can detail what kinds of accommodations a patient might require to help them attend school more often, get from place to place within the school building. So we help families put these together, wheelchair accessibility planning, that is school schedule, so a kid doesn't have to go from a class at this end of the school to a class at that end of the school while the hordes of elephants are in the hallway. Trying to avoid, any kind of safety concerns, and that includes adaptive phys ed and avoiding contact sports. We sometimes can have there be scribes to get notes at school for the high school kids and give them extra time to complete exams and projects. Next slide. And then the most detailed kind of plan is called an IEP, which stands for an individualized education plan. And this is generally reserved for patients who have more significant issues, which is impacting their school attendance and performance. It might include an assessment by either an OT or an occupational therapist or a PT physical therapist to help optimize the accommodations. And then many of my patients use hybrid school programs. So if they're just not feeling well or they have an intercurrent illness or whatever it is, they can do the work online and then have some in-person activities when they're better able to handle those. Next slide, please. So I'm not going to spend a lot of time talking about pain management because I think you're going to hear a lot about that from other speakers over this conference. But one thing I often wanted to mention is I have involved my chronic pain team in my hospital, and that's to help people who have really significant pain issues that's impacting their quality of life. And there are many different helpful medications that we can use. And also our chronic pain team has psychologists who work with them to help patients get through some of the mental health chronic concerns associated with chronic pain. Next slide, please. So one important thing to realize is that a patient with a child with medical complexity might not have just one of these issues I've discussed, but they might have all of them at the same time. So it's really important to think about all of these different things. And even having just one of these issues can be a challenge and requires really quite thoughtful and sometimes multidisciplinary management. Next slide, please. So this is a summary slide Nutrition is extremely important, getting adequate calories, um, and getting adequate fluids to help with the kidney stone issue. Respiratory problems can be a factor. Pain team consultation might be very helpful. And then there are many, many ways we can help kids in school. Next slide. And so every child is unique, and it takes common sense and looking at that child specifically, sometimes a team of specialists and working with the nurse at school to really help make things go well. Next slide. I think that might be the last one. So thank you for your attention. It's been my pleasure to talk with you today.
Thank you, Dr. Elias. We'll look forward to seeing you back on the screen shortly for Q&A. Our next presenter is also, and this is the last one for this session, virtual. Hi, Dr. Al-Muqaddam, can you hear me okay?
Yes, I can.
Very good. Sorry, I'll hand it over to you, Mona.
Can you hear me fine? So with the slides, I see my face on my slides, and I don't know if that can be moved.
Hi, Mona. Yep, we can hear you great. I was just saying I'll hand it over to you to get started.
Okay, great. No, because my picture was, yeah, perfect. All right, hi, everyone. Sorry I couldn't be there in person. My reason is my kids. And so this was predetermined that I wasn't going to fly in. But thank you for having me. So what I'm going to be talking about is the health of our normal bone in FOP. You know, a lot of times in FOP, we always focus really on the extra bone. And as Bob Pignolo mentioned, you know, there's a lot of things that we recognize are very common in our FOP patients. And there's a lot of effects of the FOP on different organs of our body, but also on our normal bones. And so today, that's what I'm going to be talking about. Next slide. So other than the work that I do with FOP, I also see patients with a very, very common disease called osteoporosis. And so osteoporosis, by definition, it's bone that has a lot of holes, a porous bone. And that is a bone that has low density, so there's not a lot of bone. And that is a bone that's weak, so putting the bone at increased risk of breaking. So if you can see in the slides below, this is a vertebra, so this is a bone in the spine. On the left is the normal bone. So this is, you can see that the bone is very dense. There's a lot of bone, and that bone is connected very well. And that bone that comes from the spine is strong, and that's normal bone. Versus on the right hand, you have an image of a bone from a vertebra which has a lot of osteoporosis. So you can see there's a lot of holes in that bone. You can see through it. It's almost transparent. And that structure is not going to be strong, and it's at very high risk of breaking. Next slide. And so what are the symptoms of osteoporosis? Well, that doesn't cause any pain. So someone can have really bad, poor bone quality, can have a lot of holes in their bones, but not have any symptoms until they break the bone. So until there's a fracture, we can all be walking around having osteoporosis and not knowing that. But we also recognize that although it is silent disease, it is a major public health problem. So about 50 million Americans, adults, and that's really in adults, have low bone mineral density or osteoporosis. And that's responsible for about 2 million osteoporosis-related fractures every year. And so why do we care about these fractures? Well, we care about these fractures or the bone breaking, not only because of the pain, which could be pretty tremendous and debilitating, but it can also put the patients at increased risk of death. And also cause a lot of pain, loss of independence, but it can also cause significant respiratory issues as well as gastrointestinal issues. And as you have seen in the prior talks, that's also something that we really worry about with our FOP patients. And so, we really want to try to avoid anything that could further worsen their underlying breathing and gastrointestinal issues. And of course, just because we all care about that, that's associated with a lot of cost, health-related cost. And so even in the general population, and forget FOP alone, osteoporosis continues to be an underdiagnosed and undertreated condition. Next slide. And so what about our FOP patients? What do we know about osteoporosis and fracture risk in our FOP patients? Well, we know it's high. We know a lot of our patients are at increased risk of falling. And when they fall, they don't have their hands or they don't have the ability to self-correct. And so the risk of injury is even higher with the falls in our FOP patients. So that alone, we know a lot of our patients fall and break bones. But what we also have seen in our FOP patients is that they have very low vitamin D. Again, mentioned in the talk before that. And so low vitamin D, whether it's due to nutritional deficiencies or not being out in the sun, can also cause weaker bones. We also know that our patients seem to have more kidney stones, and kidney stones are also associated with poorer bone quality. Obviously, of no fault of our patients, but they're, by the second decade of life, they're usually in a wheelchair, they're inactive, they're unable to move, and that's also not very good for the bone health. Having low estrogen and low testosterone can also contribute to poor bone quality. And the other thing to think about with our FOP patients is medications. So what medications are we prescribing for people living with FOP? And do these medications have negative effect on bone quality? Well, one medication that Bob Pignolo mentioned and that we use frequently and have been using for decades is glucocorticoids, or the medications prednisone or Solimedrol, and those are the ones that we use during an acute flare-up in major joints or before or after major trauma or before surgery. And so those medications can cause muscle weakness, but they can also have direct effects on the bone quality and can also, increase risk of fractures. So in this picture there, this is the skeleton of Carol, who lived with FOP. And this is her skeleton that's being displayed at the Mutter Museum in Philadelphia. And I know that the image probably, you cannot see it and cannot appreciate how transparent her normal bone is, her normotopic bone is. But if you ever go in person and you can look at her shoulder and look at the clavicular bone, the one on top of her shoulder, it's almost transparent. And her bone is very delicate. And so Carol, when she donated her skeleton to the Mutter Museum, she had asked that her jewelry be displayed with her. But because of her bones being so weak, it couldn't even carry the weight of her jewelry. And so they had to display the jewelry in a box in front of her as to not, have her normal bone shatter. Next slide. And so how can we check if someone has osteoporosis? So you can, maybe now after this talk, a lot of FOP patients will reach out to me saying, what if I have osteoporosis? How can I find out? Well, in the general population, in the general patients that I see in the adult world, we usually do an X-ray based technique called DEXA scan, which is basically the table that you see there. The patient can lay flat on the table and we do an X-ray of the spine and the hip, and we measure the areal bone mineral density. But positioning is extremely important for this test to be reliable. And also, we don't want to have anything overlying these structures that could affect the readings of this bone mineral density. So next slide. So as you can imagine, with people living with FOP, they have quite a bit of limitation that prohibits us from being able to position them appropriately on the table. And also because of the way their joints are fused or ankylosed, you could potentially have, the arm coming over the spine, the lower part of the back, and you cannot exclude that from the X-ray or from the analysis. And also all the extra bone that happens in the spine will also affect our ability to measure the density of the bone in the spine without excluding the things outside of the spine, without excluding the bone that is outside of the spine. So we knew from for a while that DEXA is going to be completely useless when using it in people living with FOP. Next slide. So there are new modalities that are being looked at using different imaging techniques. And so one that has been reported on in our FOP patients is the one developed by Tony Keaveney. And so when looking at a CT scan, and in our clinical trials, all of our patients are undergoing whole body CT scans to measure the extra bone formation. But we could also utilize these images that were obtained from the CT scan to look at the spine. And so the advantage of the CT scan, it's a three-dimensional image that we're getting. And so you could, through imaging techniques and algorithms, exclude the extra bone outside, and you can decide which area specifically you want to look at. So if you look at the image at the end of the yellow circle, you can see this is exactly, we can specify, we want to look at the density of the bone in that area of the spine. And so that allows us then to exclude all these extra artifacts that could affect the measurement of the density of the bone. Next slide. And so this is a technique that's pretty novel even in the osteoporosis world, and this is the first time that it's ever been used in patients living with FOP. And so there's a lot of limitations as well that we are potentially not aware of when it comes to using these techniques in people living with FOP. But this is the best that we have right now. And so what do we know about the bone quality measures in people living with FOP? Well, looking at the technique that I mentioned before, what we found looking at data from patients living with FOP from the MOVE study. So the MOVE study is the phase 3 study where patients were all receiving palovarotene. And the natural history study was FOP patients who were followed over 3 years and were not receiving palovarotene, but were still receiving the standard of care, including prednisone. But what we found at baseline is that most of the adults living with fibrodysplasia ossificans progressiva had very low bone mineral density. So we knew at the baseline that a lot of our patients coming into these studies had very low bone mineral density as expected, and that using the CT scan and looking at vertebral deformities, or what we call vertebral fractures, we found that about 20% of our patients at baseline had what we refer to as vertebral fractures or vertebral deformities. And so that was at baseline. But the other thing that we noted was that at 12 months, so in the MOVE study, this is 12 months after receiving palovarotene. And if you look at the last row in the table, you can see that at 12 months, in people who, in patients who received palovarotene, about 28% of them had what we call radiographic or imaging-based defined or imaging-based, imaging-defined fractures, versus in the natural history study, only 11% had what we refer to as radiographically determined new fractures. You have to keep in mind that none of those were clinically identified by patients. So patients did not come to us and saying, oh, I have this new back pain and I fell down, I had this new back pain, and we did x-rays and we found out that there's new fractures. These are fractures that were defined from the CT scan. So again, this is This is the first time that we have used these techniques in FOP patients. The CT scans that are being used in these clinical trials are low resolution CT scans, so the resolution isn't great, and that's to minimize the amount of radiation that our patients are exposed to. So, but at least what we know now from this is the first time we actually know this, is that at baseline they have low bone density. At baseline they have evidence of, compression fractures or vertebral deformities, and there's a signal that palovarotene could potentially worsen bone mineral density and increase risk of fractures in the spine, as defined by imaging techniques. Next slide. So what to do right now for our patients? I think, the prior slide as well, kind of talking about optimizing nutrition is really important. And so we try to modify risk factors, try to eliminate things that we know could affect bones negatively. So we don't recommend our patients to smoke for their breathing issues, but that's also, smoking is not good for their bone issues. Drinking too much alcohol is not good for the bone issues. And so we really try to minimize other risk factors that could affect bone quality negatively. We also recommend adequate calcium intake. And so we try to shy away from excess calcium supplementation because of the increased risk of kidney stones that we see with excess calcium supplementation. But we do recommend adequate calcium intake, best to get from diet and, dairy products, green leafy vegetables, food items that are rich in calcium are recommended. We do recommend vitamin D supplementation. And, as mentioned in the prior talk as well, we try to aim for normal vitamin D levels. And of course, we don't want to put our patients in bubbles, but as much as possible, we really talk about, fall prevention and, how to take care so that, if, using some assisted devices so that they can decrease risk of falling. Next slide. We do have medications as well that are approved to decrease risk of fractures. Those medications that I'm going to be talking about could potentially be used in FOP, but we know that they are effective, at least in our general population who have osteoporosis. The most common medication that we have used in our FOP patients are the class of medications called bisphosphonates. So you might know the names are like Fosamax, Actonel, Boniva, and those are the ones that we can give as a pill form. But we usually don't recommend the pill form for our FOP patients. We usually go for the intravenous forms like IV zoledronic acid, which is given once a year. And then IV pamidronate is sometimes used in our younger patients, but it has to be given over 3 days. And, IV pamidronate is not approved for treatment of osteoporosis per se, but we have used that in FOP patients, especially in the setting of having relentless flare-ups and requiring a lot of prednisone. But those are, 2 medications that we have definitely used quite a bit in our FOP patients and can help to strengthen the normotopic bone and hopefully decrease risk of fractures. Things to think about is, we have to make sure that the calcium and the vitamin D are replete. We don't use it in someone who has impaired kidney function or renal failure, and we have to make sure that there are no active dental issues or abscesses that might require dental extractions or dental implants. In terms of the other medication, which is denosumab or Prolia, that is approved for osteoporosis treatment in adults. It's also approved in certain cancers as well as in high calcium levels. I personally would not recommend that right now with our patients with FOP, just because it's a very reversible drug. And so patients would probably have to be on it for the foreseeable future. And so for that reason, I personally would not recommend that in our FOP patients, but it is something that can be considered. It has been associated also with potentially increased risk of infection, so that's also something to keep in mind. In our younger patients, if they have evidence of, estrogen deficiency or testosterone deficiency, I think it's very reasonable to try to replace that in our younger patients. So hormone replacement could potentially be used to strengthen the bone. We do have to think about certain risk factors that our patients might have, especially concerned with blood clots, especially in our sedentary patients as well. And, we think about that. But we have been able to use hormone replacement as well as oral contraceptives safely in a lot of our younger FOP females. Next slide. And so in summary, falling down and breaking bones is very common in the general population, but definitely also a huge concern for our patients living with FOP. Medications that we do use in FOP can decrease bone quality, like prednisone, and now the data with palovarotene. So it is something that we have to really think about. Fall prevention, adequate calcium and vitamin D is extremely important for all of our patients, whether they've had fractures or not. And we can consider medications like bisphosphonate to help protect the normotopic bone. We definitely need more studies to better understand how best to measure bone quality in our FOP patients, to really better understand the long-term side effects of the medications we are using with FOP on bone quality and fracture risk. As you can imagine, the original studies with, palovarotene, we're looking at the use of these medications for 3 years. FOP is a chronic disease, so we expect the use of these medications lifelong. And so how does that affect their, lifelong risk of having fractures? And really trying to have a better idea on what is the most effective in our FOP patients. A lot of the use of certain medications is really extrapolated from information we know from the general population, but it's really important for us to know, does this work for our FOP patients? Next slide, and I think I'm done, and I think Ed Chow is coming up next. So thank you so much for your attention, and sorry again, I couldn't be there in person.
All right, good morning. So first of all, thank you everyone for being here. I'm Ed Chow. I'm from the University of California in San Francisco. And I want to start by thanking the organizers for this chance to talk to you a little bit about one of the topics that I think was very popular in terms of the submissions. So we're going to talk a little bit about off-label medications. Okay, so for today, what we're going to do is talk a little bit about this concept of off-label medication use, specifically in FOP. And I have a couple of disclosures, and just to let you know, I am part of the clinical trials for Ashibio and for Clementi and Ipsen, also with Ascendis, and then we do have a number of other funding sources. One of the key things that I do need to say is that these opinions that I propose today are my own. They do not reflect the ICC, the IFOPA, any of the other physicians in this room. And so thank you for understanding that. Oh, and I will not be giving anybody recommendations about specific uses in your particular case. Okay, so as you can tell, this is a big deal with the disclaimers. When we talk about the off-label investigational therapies, we don't want to endorse use for any particular person at any point. And the opinions are, again, mine. And it's really important to consider that if you're considering any of these types of medications or any of these types of strategies, there may be interactions with existing medications that are not going to be particularly well known. And so I'll try to highlight some of the ones that we do know about. Some of these medications may actually exclude you from clinical trials. So before you even consider sort of these types of medications, make sure you talk it through with your physician and make sure you talk it through with any of the research teams that you may be involved in. Okay, with that, let's start with talking a little bit about what exactly an off-label medication use is. So when you look at the medications that are approved in the United States, there's, and around the world, there are approved indications, meaning that this is a use of a particular medication that has been tested and validated through clinical trials or through general acceptance. And the FDA has said, we think that this is safe. It's okay to use in this particular condition. When we talk about an off-label medication, and these conditions are actually listed on the label of any medicine. So if you get your medication, you can pull up the label off the FDA website or in the package, and it'll have a list of what the indications are. An off-label use means that the medicine has been approved and has been shown to be probably efficacious in a particular set of settings, in a particular set of diseases, but what you're trying to do is to use this medication for another purpose that may not have been as well studied. And so the off-label medication is basically the use of a drug or a medical device for a purpose that is not included in the drug's original approval labeling. So physicians have discretion to prescribe these medications because these medications are already approved for under different use. And it's typically they do this if they believe that it's medically appropriate for a specific patient's condition, even if the use is not in that original label. So this is a common and accepted practice. Healthcare providers do need to exercise caution to ensure that the benefits do outweigh the risks. And an important thing is that insurance may not cover your off-label medication use. Okay? So, and actually, just a quick note on that. We've started to see a number of insurance policies have a specific phrase, "We do not cover off-label medication use." Okay? So if you are, since I think open enrollment is like now, make sure you check it because it makes a big difference. So pretty much all of the medicines, except for one, is considered off-label medication use, but it is standard of care for our patients with FOP. And so this includes things like steroids. I can use the pointer, but I can only point on one screen at the same time. So these include steroids over here, which are used for inflammatory disorders, and it's used in FOP basically for managing flare activity. Non-steroidal anti-inflammatory medications, so these include things like ibuprofen and celecoxib for pain. The pain part is approved. Use for blocking heterotopic ossification is not approved indication. And the other big one that we probably use a lot is montelukast. This is used for managing, typically used for managing asthma and reactive airway diseases. And in FOP, it's because of the mast cell activity that is seen in developing heterotopic ossification lesions. And so the hope is that this will actually also inhibit those mast cells that are present. And that is an off-label use. So when we talk about off-label use, the key things that people want to consider are what are the indications? If the indications are similar, if there's a clear rationale that you want to consider this. So for example, montelukast, we know that mast cells are present in the lesions, that they're probably activated. And so blocking them maybe will have benefit, right? So that's a rationale for that. Common practices, so you're really looking to make sure, if the general population uses a particular medication, then that would be okay, potentially. But keeping in mind the potential risks and considerations. So for example, if you use a particular medication, there may be a side effect that would be potentially a big problem for patients with FOP, right? So these would be things like infection or complications of breathing and stuff like that. And then regulatory oversight. It's really important to keep in mind that although using an off-label medication is legal, and it is something that is allowed, there is no regulatory body that actually checks to make sure that things are safe. And so there could be liability concerns that are associated with this. Okay. The other thing to keep in mind is just sort of in the spectrum, since we're talking about the different aspects today, is that off-label medication use should be considered investigational. In other words, we really don't know a lot about these, and I'll show you some of the limitations that we have a little bit later on. So it is really important to keep in mind that there are a number of clinical trials for rare diseases and specifically for FOP. I think as was mentioned, there's about 10 trials that have gone through. And these often will focus on one target and potential therapeutic at a time. And basically what we're hoping is that we can get some early anecdotal experience with an off-label medication. So for example, as Dr. Pignolo had mentioned, some of this would be, in some senses what we call drug repositioning, taking existing medications that are out there, having had them tried in a patient with FOP, and then using that experience to try to inform the next steps. And so these are going to be things like case reports or other discussions between the physicians, and it may suggest useful parameters in terms of the use of these particular off-label medications. And then real-world clinical settings. So in the end, each patient is an individual, and there's going to be different aspects that need to be cared for. And so there may be situations where you just have to use a medication off-label to try to manage some of those symptoms. But again, the key thing is that the risks and benefits are really unclear, and especially for some of the less common medications that are used, these need to be discussed beforehand. Okay, so again, disclaimer. Basically, the key things that I just want to bring up again is that we're not going to be talking, about off-label use. And one thing down here that I really want to emphasize, and the ICC has really tried to emphasize, some of these medications are available from like China or other places as non-pharmaceutical grade. Do not use those. Okay, please don't even think about it, because those are contaminated, they are not purified, we don't know anything about them. Don't use those if they are non-pharmaceutical grade. Okay, Dr. Pignolo also mentioned that the ICC has issued a statement about the use of off-label medications. I would strongly suggest that you take a look at this if this is something that you're considering. It gives you a lot of guidelines and a lot of sort of things to keep in mind. And I think it's very valuable to consider. Okay, so let's step back and think a little bit about the different types of medications and what we're talking about. So with any sort of therapeutic strategy, especially for like FOP, there are going to be things that try to target direct targeting of the mutation. And these are going to be things that are going to be much more disease-specific, so FOP-specific. But there are going to be pathways that could be potentially blocked, right? And these are going to be more generalizable. And so the only drug that is really dedicated specifically to FOP is palovarotene. But there are a number of potentially off-label medications that have been reported in the literature that might actually have some benefit. I chose a couple just to sort of highlight. We're going to talk a little bit about imatinib, because that was one of the first off-label ones that had clinical cases that were presented. Canakinumab and tofacitinib have recently garnered a fair amount of attention, and then also rapamycin and apigenin. Okay, so these are the groups that we're going to talk about. And the way that I decided to do this was to focus based on mechanisms, in terms of how these different types of drugs act. So what we have really established over the past 10 years is that inflammation is a key driver of FOP. And there have been a number of different papers now that have reflected this. This was actually just some of the most recent papers, but if you look in the literature, there are a number from our lab as well as Eileen Shore's lab and other labs from around the world. And this is just some of our data, just to give you a little bit of background. These were patients who had come to UCSF, and we were very fortunate to collect blood samples from and to look very carefully at their cytokines. And what I want to point out is that there are a couple of cytokines here called IL-1, so IL-1RA and IL-1 beta, that are increased in patients with FOP. And this actually provided a lot of the initial rationale for thinking about how you could target the immune system and see whether or not that would decrease FOP symptoms. So one of the first ones that was actually looked at is this set of medications, anakinra and canakinumab. Anakinra is basically a small molecule blocker that actually prevents the binding of IL-1 beta and IL-1 alpha, so it actually acts at the receptor and blocks that. And then there's a different medication called canakinumab, which itself is an antibody, and what it does is it binds IL-1 beta. And the reason we think about IL-1 as being important, IL-1 is the cytokine, that's the hormone that is produced by your body that causes things like fever, inflammation, a lot of those types of symptoms of a really inflamed process, and it activates the entire immune system. So anakinra is a daily injection. These are all subcutaneous. It was approved in 2001, so it's got a long track record of use, particularly in kids. It's approved for these conditions, which is familial Mediterranean fever, stills, rheumatoid arthritis, and cryoporphyrin diseases. And canakinumab came a little bit later. It was in 2009. It's nice because it's a monthly, it's usually every 4 to 8 weeks, depending on the condition. A monthly IA to every 2-month injection. It's an antibody. It's again also approved for similar indications, so Still's, juvenile rheumatoid arthritis, cryoporphyrin diseases, Muckle-Wells, neonatal multisystem inflammatory diseases called NOMID. So again, these medications have a long track record of being used. And in many of these situations, these medications go down to age 2, if not younger. So this is Ruby Haviv's work that he had actually, in Israel, had been able to treat 3 patients with FOP with anakinra and canakinumab, and we had 1 patient at UCSF that was also treated with canakinumab and anakinra. And the key aspect here, I think, as Dr. Pignolo mentioned, a lot of these initial case reports are based on flare activity, not heterotopic ossification. But what you can see is that the flare reduction rate was pretty significant. So it would go down by somewhere between 60 to 90%. And so this actually has provided the basis for a lot of interest in using these medications. I will note that just from our own experience, the anakinra does seem to work in some patients. It has worked very well. But a lot of patients, both FOP and non-FOP, complain of injection site pain, which is common because anakinra is slightly acidic. And so they don't typically tolerate it very well. And just as a plug for our UCSF, we have an observational study for the use of canakinumab in FOP that will be opening in early 2025, and we can talk about that separately. The other medication that has come up recently is tofacitinib. This is what we call a JAK inhibitor. So all of the cytokines, so again, these are the hormones that mediate the inflammatory response, all of the cytokines signal through receptors that have this kinase as part of the signaling pathway. And the interesting thing about tofacitinib is that it is known to block the signaling of all of these different types of cytokines. So it's a little bit less specific than like canakinumab. Canakinumab is only IL-1. This one is actually broader and covers a lot more of the different types of cytokines. And what we do know is that all of these different cytokine pathways are really critical for things like the antiviral response, for immune cell production, and for blood cell production. And so when you look at it, this is where a lot of the side effects come from. So tofacitinib is an oral medication, which is nice from that standpoint. It's a daily medication. But it also has a black box warning. So a black box warning is what's been issued by the FDA for the approved indications, but the black box warning is the most important sort of contraindications and things that physicians have to look out for. And so a lot of different medications actually have this. So the black box warning for tofacitinib is that there could be serious heart events, so cardiac events, an increased risk of cancer, increased risk of blood clots, and death. And so these are factors that need to be taken into consideration, especially since patients with FOP are sometimes not particularly mobile. And because they're not as mobile, they are at increased risk of things like blood clots. The cancer is interesting because we're not entirely sure, that it's right now this is all-cause cancer in tofacitinib, but there seems to be a specific concern for dermatologic cancers in tofacitinib, especially melanoma or non-melanoma, those type of lesions. And patients with FOP already are known to have skin issues. And so we don't exactly know what the impact of these potential risks are. This is the case series of off-label use of tofacitinib that was published by Dr. Nishikina and their group in 2023, and I think many of you have seen this. But basically, this was 13 patients. They received 2 years of treatment. During this period of time, there was no significant change in their CAGES scores over 2 years. But I will note that based on the natural history study, 2 years is kind of the borderline in terms of being able to see any change in the CAGES score, because the CAGES score is just not super sensitive. 31% of people reported increased range of motion and some improvement, and then there was also improvement in flare activity, which you can see over here. There was no quantitative radiology. There was qualitative radiology that seemed to indicate decreased sacroiliac joint involvement. But again, we don't have any sort of clear quantitation at this point. So for canakinumab and tofacitinib, both appear to decrease flare activity in FOP patients. Side effect profiles are important to consider because of the tofacitinib, infection, blood clots, liver toxicity, possible cancer risk, canakinumab, infection. The long-term toxicities and benefits for FOP are still completely unknown. I will point out for both of these, there's really no mouse data. And as I had mentioned, we don't really use anakinra as much anymore in patients with FOP due to the difficulty of taking the medication. Okay, so that was this section here, blocking the inflammatory pathways. I'm going to move on to HIF-1 alpha blockers. So one of the things that we know about heterotopic ossification in general, and specifically also about FOP, is that low oxygen hypoxia is a major driver of bone formation. And this is one of the reasons why we, as clinicians, are very, we keep emphasizing, did you do your respiratory exercises, things like that. That's part of it, is really sort of maintaining this. But we also know that things like multiple blood pressure measurements or prolonged tourniquets and things like that, that can trigger a flare, and that's what we worry about in those particular situations. HIF-1 alpha is the hypoxia-inducible factor. It's a major gene that's expressed in response to low oxygen. And this typically occurs if you have tissue injury or damage. So one of the medications that was first identified for this, I don't think it was the first, but it was one of the medications that is known to affect the HIF-1 alpha pathway, is called rapamycin. And rapamycin, this was originally identified for use in FOP through a human iPS cell drug screen where they were able to use iPS cells that carried the FOP mutation, screen them in vitro to look for any drugs that would actually change the bone morphogenetic protein signaling pathway downstream of ACVR1. And it suggested that this would be a potential target, and when given in mice, you could see that in the mice, there was actually pretty significant reduction in the heterotopic ossification in these mouse models. The challenge has been whether this is also what happens in humans. And so there was one case series that has been published in patients with FOP who have taken rapamycin. And in those situations, those two patients, they still had progression while they were on rapamycin. And there is a clinical trial that's ongoing in Japan. We have not seen any results about this yet. The original group that identified rapamycin was over in Japan. And so we are hopeful that those results will come out sometime soon. Another medication that Dr. Paniello had mentioned is this nutraceutical called apigenin. Apigenin was originally tested in shed cells, and so for those of you who have very kindly donated things like teeth and baby teeth, thank you, because that's one of the key models, those are super valuable for understanding FOP. But in these shed cells, they were able to show that apigenin could decrease the BMP signaling back into the normal range. In the mice, these are mice that were treated with apigenin. Sorry, apigenin is this one here in the middle one, that's gray. And you can see that it looked like that the percentage of mice that sort of retained mobility was higher and that there was actually reduction in the bone volume that was present. So this seemed to be very suggestive of potential benefit. And so no, but we don't actually have any human data on this. And as part of this study, this was by Haitao Wang and Bob Paniello's group, imatinib was also tested. And imatinib is another medication that actually targets multiple places on the pathway. It's both a kinase inhibitor and also inhibits HIF-1 alpha. Imatinib was also tested, and you can see that imatinib also seemed to reduce the heterotopic ossification here and help to maintain mobility in these mice. And so I'm going to talk briefly about imatinib. So imatinib is a medication that has been used for many years in cancer therapy for chronic myelogenous leukemia and for other diseases. It has been used in children, and so there is a lot of experience in there. It is associated with bone marrow suppression activity. Dr. Kaplan and a number of other investigators actually published a couple of papers related to this. There have been 3 children with unusually severe FOP, followed by what we call on treatment, meaning that they were treated for a while, then they stopped, and then they went back on. And, and that allowed us to see what exactly happened. And during the times when they were on treatment, there was reduced swelling and improved function. Improvement seemed to show up after about 2 to 3 weeks, and that there was actually reduced flare activity. But as I noted before, there is a risk of bone marrow suppression and anemia. There's liver and cardiac toxicity, potentially some kidney toxicity, and somnolence. And so these are all not specific to FOP, but definitely something that limits the potential use in patients with FOP. All right, so off-label medications for the investigational use in FOP. So we have multiple medications that are being utilized beyond the standard of care. There are anti-inflammatory medications like canakinumab and tofacitinib, HIF-1 alpha inhibitors like rapamycin, Apigen, and imatinib. Imatinib is also a kinase inhibitor. And just to direct you towards the ICC discussion. And one of the key things that we really want to emphasize is that in the use of these medications, if this is being considered, we typically only consider this for patients who are having really severe, intractable FOP flares. Because a lot of the data just isn't known. And I think this gives you a really good sense of that. So like for canakinumab and tofacitinib, we really have no information about these cell models and mouse models. It's only the clinical observations. Imatinib, there's more data in the background, but in every single case, we really have no patient information regarding especially the ability to block heterotopic ossification. All right, so again, disclaimers. I think these are important types of therapies to consider. There is risk associated with them. This is really important to discuss, again, with your clinicians. And again, because of the unknowns, we really do try to emphasize that these are for patients who have extremely severe FOP. Flares are not controlled by other sort of mechanisms, the standard of care mechanisms in the ICC treatment guidelines. Okay. And with that, I will stop, and I think we are going to do a panel, right? So.
Well, I want to just start before we jump into questions by saying thank you so much to all of our doctors who presented today. I know there's been some great presentations, and it's really a wonderful way to start off our time together by hearing in depth from each of you on topics that are really important to our community. I don't see anyone at a mic yet, so I am going to start. We do always get quite a list of questions that people submit ahead of time, so I'm going to start with one of those and give you all a chance. One of the questions that has come in is about potential studies or research areas that are being looked at, and a family is wanting to know if there are any studies to test metformin or tetracycline in inhibiting MP9.
I'll take that one. I hold that question till tomorrow. Okay?
Thank you, Dr.
Thank you.
Kaplan. So I think that was a soft cue for Dr. Kaplan's talk, which will be taking place first off the bat tomorrow morning.
Good answer.
Another question that we have submitted in advance. So we did hear Dr. Elias talk a little bit about pain, and I know that is a really important topic for a lot of our families. The IFOPA has focused on pain in every family gathering and in our programs throughout the year, and we have a library of resources on our website and on our YouTube channel. But someone submitted a question to ask about flare-up pain specifically, and they're curious to know if flare-up pain if pain during flare-ups can sometimes occur in other areas of the body that are not flaring at the moment.
I think the short answer is yes. I think although having multiple flare-ups is sometimes a little unusual, there's things like referred pain. There can be a spasmodic component to flare-ups which may carry to other sites or adjacent sites. So I think the short answer is definitely yes.
Thank you.
And I would add to that so Xiaobing Yu, who's a pain specialist and anesthesiologist, has done a number of studies actually looking at pain sensitivity in patients with FOP. and has identified that the ACVR1 mutation itself actually can change the ability to sense noxious stimuli. So there is an increased sensitivity to mechanical stimulation, increased sensitivity to temperature, which actually correlates with what a lot of the patients have reported to us. And I think that goes back to what Dr. Elias had actually mentioned before, is having a pain management team is absolutely critical, because there are a number of different types of medications that are worthwhile testing, and that this can be not just flare pain, but actually sort of syndromic pain, that there's pain in other parts of the body.
Hey, one of the things I was going to mention is that can be very tricky to sort of pinpoint where the pain is coming from, is I have had some patients who have developed intra-abdominal or pain down in the pelvic region, and that can be related to to calcification and say some of the pelvic floor muscles, and that can present as sort of more diffuse pain. It's hard to figure out exactly where it's coming from sometimes. Can mimic things like appendicitis. And so I think if there's pain like that and presenting like that, it's really, really important to try to make a diagnosis and figure out what's happening to cause pain. Like maybe thinking about a CT to rule out appendicitis, to know what the best intervention might be.
Thank you, Dr. Elias. And Mona, did you have anything to add? No? Okay. Oh, I can see you much better now. That's great. Okay, so the majority of the community, is more of the classic FOP genetic, but there are some members of the community who do have the variant form. And so the question from the audience or from attendees is, are there any specific focus or interest in potential studies on FOP variants?
So many of the drugs that were mentioned this morning by Bob and Ed, and traditional drugs that are used for FOP also work on the FOP receptor. I think it's very important to keep in mind that all the variants that have been discovered so far have been in the ACVR1 gene. They're just in different places in that same gene, and they all activate the gene. They all, activate the receptor. So it's a gain of function. So whether more bone is formed or less bone is formed than in the classic form of FOP is up for question. Many of the drugs, not all the drugs, but many of the drugs that are being tested now in clinical trials will be useful for FOP. And some of the clinical trials actually allow patients who have variants to enter. That's not a disqualifying factor. It's possible that some of the drugs that are eventually approved will not be used for variants, but most of the drugs that are currently in practice will work. We anticipate that they would work on the variants just as well as they would work on the classic form of FOP.
Thank you, Dr. Kaplan. A question was submitted about kidney stones, and I know that was mentioned briefly at a couple of points, but in terms of managing kidney stones, Dr. Pignolo, I know that's a topic you've discussed in the past. Do you have any recommendations you would share?
Sure. So the treatment and management of kidney stones is really the same between FOP and the general population. So in terms of prevention, it's, keep well hydrated, keep well hydrated, keep well hydrated. But other things to consider is to use in moderation things like sodium in your diet, so salt in your diet, avoiding high protein diets. These are things that can, in excess, really precipitate kidney stone formation. couple other things to consider. I think one is that there's a sort of a fallacy that if you're predisposed to kidney stones, you shouldn't be taking, or should avoid calcium. I know it's counterintuitive, but if you purposely reduce your intake of calcium, you actually increase the risk for kidney stones. So as Mona pointed out today, you want to have adequate doses of calcium. You don't want to take in excessive amounts of calcium, but you do want to take in normal amounts of calcium. And you know, if you have kidney stones already formed, you know, unless they're symptomatic, we wouldn't try to remove them with a urologic procedure. But obviously, if it was you know, causing obstruction or something we call hydronephrosis, where the urine can't adequately come down into the bladder, then you know, those same procedures would have to be cautiously used.
And we have a question from the audience. Lori?
Hi, Mona. This is Lori Henrote here. So just wanted to say hello because you might understand the question a little bit as well. Carly is 28, and I want to mention that, Ed, because of how you talked about the curve and age and what we've talked about. She has been in an incredible flare-up for 2 years in her back. She's really can't take any more prednisone, and I know you don't use it for the back anyway, but it's incredibly inflamed. She is in the worst pain I've ever seen in my life. She won't let me touch it, and I can tell it's very inflamed. So I don't know where to go. I guess my question is there anything else like CBD or anything that can help with inflammation or pain or things that we should be doing?
Thank you, Lori. I think, obviously, for Carly specifically, we can talk about this offline. So I think it's going to be very hard to specifically address Lori's pain. I think regarding CBD use, I'm going to actually have Ed take that on since it's also related to kind of better pain management.
Thanks, Mona.
You're welcome. Plus, my voice is echoing, so.
So it's too bad Xiaobing Yu is not here because he's in our chronic pain service. There have been a number of patients with FOP who have used CBD that we know about and have gotten mixed results. So I think some patients, you know, just like any other medication, there are going to be some patients that respond and some patients that don't. And you know, it's a little bit tricky because getting the CBD is often difficult depending on what state you're in, you know, your local restrictions. In addition, one of the big challenges with CBD and THC is that they, you know, the preparations that are made, there's no clear standardized system for actually quantitating it and quantitating the purity. And so that means that, you know, you can get it from one supplier versus a different supplier and have totally different effects. We do have a few patients who say that it does help to decrease the pain and to some degree the inflammation. Most of the patients, and this is purely anecdotal, most of the patients seem to be taking topical rather than oral. And so, you know, if it comes down to that, again, you know, one of the challenges with FOP is that there's really only one on-label medication, right? And so we have to think outside the box and think about what we want to do to strategize for the management of these situations. And so since I think Carly sees Mona, I will punt it back to Mona to make the decisions.
It was more of a general.
Yeah, I think definitely we can.
General question
Yeah.
as well, Mona.
Yeah.
It's more
No.
in general, what can you do for swelling in the back or somewhere else? Is there anything else?
I didn't hear Lori's follow-up question, but I did want to comment about the CBD and the route. And so, topical should be fine. Oral, we have to check if it interacts with any of the study drugs. And the third thing is what we do not recommend at all is inhalation or vaping or smoking because of the respiratory issues that we have. And so I think thinking outside of the box is something that we are willing to do always, but not if it's going to affect the safety of our patients. And so we never recommend any smoking or, that kind of route for pain management.
Thank you, Mona. And we do have a question about lymphedema later, so we can get to that. We can maybe come back to the swelling, Lori, if we get to that lymphedema question. But Kimmy, did you have a question?
Actually, before you do that, I think Dr. Elias has a comment. And actually, she has a great pain team that works with her, so maybe she can comment on that too.
Kimmy, hold for 1 minute. Dr. Elias, go ahead.
Thanks. So I just wanted to make sure I reemphasize the no vaping thing, because people need to work really, really hard to protect respiratory function. But the other thing I was going to say as a pediatrician is no matter what state you live in, CBD is illegal in pediatric patients. Let me say that again. CBD is illegal in pediatric patients. I can't prescribe it. Nobody can prescribe it unless it's part of a research study. It's used sometimes in kids with bad seizures, for example, on a research study. But otherwise, adults can walk in and buy these things that look like candy and taste pretty yummy, I've been told, but they are not legal in children, period. Don't do it.
Thanks for emphasizing that.
Yeah, that is an important point to make. So thank you, Dr. Elias. Kimmy, you have a question?
Okay, so it's a little personal to bring up, but I figured maybe just having the whole panel instead of just talking to one doctor about it would be better. So I have a almost large uterine fibroid, so it's probably going to lead to some kind of intervention. And I was just more for Mona to see if anyone could just fill me in on what my options are. I have my follow-up on Tuesday, but I just kind of want to get a heads up on it.
Sure. And again, similar to other patients, you can always email us directly with personal questions. The uterine fibroids are extremely common. And we have seen a lot of our FOP patients complaining of uterine fibroids. The treatment really depends on your symptoms and what is bothering you. And so if it's bleeding, excess bleeding, then we can talk about starting medications to decrease the bleeding. We have used, oral contraceptives sometimes, and there's other medications that can be used also to decrease the bleeding. If the problem is size, then that will require as well different treatment options. Some of them could be hormonal to decrease the size, but it might not be a long-term option. So it also depends on whether you're looking to preserve the ability to get pregnant or not. We have had FOP patients successfully undergo hysterectomy, but again, it needs to be thoroughly discussed. Talk about what are the symptoms that are bothering you the most, and we try as much as possible to use non-invasive methods to treat uterine fibroids. And unless those don't work, then there's the option for surgery.
Can I just add something really quickly? So it is, we actually don't know whether fibroids are actually part of the FOP spectrum or whether there are other sort of conditions related to irregular periods and things like that. So I encourage you, I think Sammy mentioned this last night, there is a one-time survey that is out on the IFOPA registry database. If people can fill those out, that would be super helpful because it's looking at puberty, it's growth, it's looking at gynecology, That would be really helpful, I think, for the field.
Thank you, Dr. Shao. Another question from the audience.
Hello, my name is Jason Scott, I'm Anthony's brother. I was in the military, and they did a thing called a bone scan. They use nuclear medicine. Is that a way to do bone imaging?
I will take that one. So there are a lot of bone scans that you can refer to, so it's hard to comment about which bone scan you're referring to. In terms of bone scans, we could do them in FOP patients, absolutely. But it depends on what question also you're trying to answer. So in terms of measuring bone density, bone scan is probably not going to be helpful. If we're looking at the bone scan to see if there's any active lesions or new bone growth, that sometimes we have used that, but not clinically in a way that is going to be helpful to change the management in our FOP patients.
Thank you, Dr. Al-Muqaddam. I think, Mark, do you have a question?
Yes, first of all, thank you to the scientists and the clinicians, excuse me, for your magnificent work to get us to this part of the journey. If we were to compare the pursuit to a treatment and a cure to, say, like a marathon, what mile marker are we at, and what are the milestones left to get us to the finish line?
Well, I think there are 26 miles in a marathon, right? I think maybe it's more informative to talk about what the milestones are, and you can decide, what mile marker that translates to. But I think we need effective treatments that can reduce the onset of new flare-ups and subsequent bone formation by at least 90%, for it to really, I think, significantly change the natural history or course of FOP. And of course, if you could reach that milestone, then you open up the possibility of using drugs that are very efficacious to surgically release ankylosed joints. And so, we can target younger and older individuals for benefit. Now, the milestones also have to confer adequate safety. And so I think that's an open question for some of the therapeutics that we're studying as well. So we need not only safety, but long-term safety. So I think probably we're, conservatively, we're at mile marker 13.
I'd just add, I thought you touched upon a very good point this morning, that the battleground for FOP is in childhood. And as June Osborne from the University of Michigan said in a different context many years ago in an editorial in the New England Journal of Medicine, she said, when prevention is done absolutely right, absolutely nothing happens. We won't have to remove heterotopic bone. And so I think we're not there yet, but we have a horizon. We know that the race, as you said, Mark, is maybe 26 miles. I don't know where we are yet. But I think when we get to the point where we're able to have efficacy and safety, like you said, in children, we'll be much further. We'll know that we're much further along. I think that's the important point. As Ed said, FOP is a very complex disorder, and it affects not only heterotopic bone, it affects the joint development as well. We know that that not only the great toe is affected, but other joints, maybe 100 joints in the body. The joints where the ribs join the spine are involved as well. The neck, the facet joints in the cervical, thoracic, and lumbar spine are involved as well. It will be very interesting to see. We won't know initially with 1 or 2 year studies, but it'll be very interesting to see in long-term effects of in long-term follow-ups on clinical trials that are effective if the drugs do affect joint degeneration. One of the students in the lab did magnificent studies on joint pathology and FOP, not just the toe, but we found that many, many joints in the body are deranged by FOP. So if we're able to decrease the heterotopic bone formation, I think, I'm not sure about this at all, of course, because I have no way of knowing, but I think in the next lifetime, I won't be around, but in the next lifetime, FOP might be turned into a chronic rheumatologic problem, not a heterotopic bone problem. In other words, we'll be able to reserve some mobility. And then, of course, we have the question, will these drugs affect, will they affect pain development? Will they affect the sensory ability of the brain to interpret these signals of pain? And many, many other things that you mentioned, Bob, too. So FOP is a very complex disorder, but I think the first thing that we want to deal with is the heterotopic bone, and that's where we are right now.
Yeah, I just want to add one more comment. So I think we might get a pretty good idea about what optimized treatment might look like from our resilient patient who's in his 30s. 36. So he makes some heterotopic bone, and we may look to him to see, he certainly has all the congenital abnormalities that we would expect from someone with an ACVR1 mutation. So we're not going to be able to change that, and I think that was one of your points, Fred. But we might look to him to see, is he going to develop accelerated arthritis and some of the other things that maybe aren't always directly related to heterotopic bone formation.
Mona, I
Talk
know
more
you
about
had
this,
your
Mona.
hand up. Did you want to add something to this?
I just wanted to give maybe some more concrete answers, just because I think our finish line, it's not one finish line that we're looking for, right? So we're trying to achieve one goal. Once we achieve that goal, there's going to be other goals, like Fred mentioned. First goal is to find a drug that is safe and works in adults. The second goal is to go into children. The third goal is to improve the quality, we're trying to improve the quality of life, prevent bone from happening, and then address other things that are outside of the extra bone that we are targeting right now. And so I think it's a moving target. And I think if we look at it as the first goal, and we think about it maybe in a more concrete way, we think about the gene discovery. We think about the mouse model and preclinical data. We think about after preclinical data, we're doing phase 1, phase 2, and then phase 3 studies until the FDA approves a drug. And so I don't know, I'm just trying to give it in a more concrete way, is that most of the clinical trials that are happening right now are phase 2, phase 3, which could be the registration study that the FDA can look at to approve a drug. So I think in those milestones we're doing really well, but it's not the end goal, right? This is the first goal, but we understand that once we achieve that, we have to do a lot of things afterwards.
And I know we had another question over there. We are eating into everyone's break right now. So I hope that you have all requested, or I know that pretty much all of you have requested time to speak with the FOP medical experts during an Ask a Doctor meeting. And that's another great opportunity to ask questions. Rico, do you want to ask yours in closing, and then we'll wrap up and let everyone get to break?
I apologize. So not knowing the number of people that were in the Palaveritine clinical trial that successfully finished it, I think earlier I heard that there's 35 that had been prescribed it, I believe, throughout the world. Is that a high number? If so, I applaud it. If it is a low number, I wonder why.
I don't know if it's a high number or a low number, because there are so many ongoing clinical trials. So if you have FOP, you have to make a decision do you want to trial a drug that perhaps you've never had before, or do you want to enter a clinical study? The other thing is, I think most of the patients that, I shouldn't say most, I think a lot of the patients that are on palovarotene did participate in the MOVE trial, and they felt that they did well on that drug. So I think it's a hard question to answer because of the current clinical trials climate, but also, you know, the motivation, the personal motivation of each patient.
Thank you, Dr. Pignolo.